احنا طبعا هنعرض الحالات هي بس عشان تبقوا عارفين. حالة الأول في البرين، وبعدين وراها حالة في الشيست، وبعدين وراها حالة في الأبدومين، وهكذا لحد لما الوقت يخلص. فتستنوا معايا دقيقة لحد لما نفتح الكونكشن مرة تانية ونكمل بقية الفيلم ريدنج سيشن إن شاء الله. نبتدي بقى بإذن الله الحالة الأولانية. Then this is the first case and you see an MRI of the brain. This is T1 and this is T2 and this sagittal T1.
Semilobar holoencephalopathy.
Holobrosencephaly. Semilobar holobrosencephaly. This is one of the subtypes of holobrosencephaly. We have the lobar type, the semilobar type, and the lobar type. And one of the best diagnostic criteria of the semilobar type is what is known as H-shaped ventricles. And you got rudimentary anterior falx and absence of the septum pellucidum and connection of the ventricles across the midline. Good. Next.
Chest X-ray, posterior anterior view.
Yes.
Right lower zone pneumonic consolidation with pleural effusion.
Very good. And this is pneumonia, patchy opacity in the lower part of the right lung associated with pleural effusion, which is extending along the lateral chest wall. Okay.
Appendicitis with the fibulus.
Yes, very good. And this is acute appendicitis. The appendix wall is swollen, and you got an echogenic structure with posterior acoustic shadowing representing the appendicolis.
Medulloblastoma of the fourth ventricle.
Medulloblastoma, yes, and this is right. This is a medulloblastoma because of the diffusion restriction. And you know that medulloblastoma is considered the only midline posterior fossa tumor which shows diffusion restriction. And now you can use the diffusion weighted images to differentiate between the ependymoma and medulloblastoma, which have an overlapping imaging criteria, but ependymoma do not show diffusion restriction, while medulloblastoma will show.
Right tension pneumothorax.
Very good. And this is tension pneumothorax. And tension because, number one, the mediastinum is shifted to the opposite side, and the diaphragm is markedly depressed.
Double bubble sign. Double bubble sign.
Yes. What does it mean?
Duodenal atresia.
Duodenal atresia.
Yes, very good. And the double bubble sign, and you got an air bubble in the stomach and another one in the proximal duodenum. This is diagnostic of duodenal atresia.
Hamartoma.
Sorry?
Hamartoma.
Hamartoma of? No?
Tuber cinereum.
Yes, hypothalamic or tuber cinereum hamartoma. And you see a well-defined lesion in the region of the tuber cinereum. And after injection of contrast material, the lesion classically do not enhance. And you can see the contrast within the vessels. And you know, by the enhancement also of the pituitary gland, that this image is injected with contrast.
Diaphragmatic hernia.
Yes, congenital diaphragmatic hernia, and you got multiple air-filled bowel loops displaced in the left hemisthorax, and this air is continuous with the air in the abdomen, diagnostic of congenital diaphragmatic hernia.
It got volvulus.
Yes, very good. And this is malrotation with volvulus, and you see the corkscrew appearance of the duodenum, which is a classic sign in the barium studies for the volvulus.
Abscess, multiple abscess, or
multiple brain abscesses, and this is pre-contrast and this is post-contrast, and you got marginal enhancement and extensive surrounding perifocal brain edema. These are multiple brain abscesses. Okay.
Lobar emphysema. Left upper lobe.
Left upper lobe.
Emphysema, congenital emphysema.
And congenital lobar emphysema. And this is now is called the congenital lobar overinflation. They omitted the term emphysema and they replaced it by over inflation, as it is not actually an emphysematous lobe, but it is an overinflated lobe. And the diagnostic landmarks here are: number one, you see the overinflated lobe is crossing the midline to the opposite side, and you can see the other lobe, the lower lobe, is compressed and flattened against the diaphragm.
Necrotizing enterocolitis.
Yes, and this is necrotizing enterocolitis. You see air in the wall of the small bowel in the neonate or the infant, and this is diagnostic of necrotizing enterocolitis. Sometimes you can see air in the portal tracts, but this is not a constant finding.
Aqueduct stenosis.
Yes, and this is aqueductal stenosis. You got dilatation of the third and both lateral ventricles with normal size of the fourth ventricle, diagnostic of aqueductal stenosis. Sorry.
Diaphragmatic hernia?
No.
CCAM.
Yes, and CCAM also, its name has been changed into CBAM. And the diagnostic clue here is the presence of barium. And if this is a diaphragmatic hernia, this barium should extend into the hernia. But while you see this barium is here, and then this is a different pathology, and this is the congenital adenomatoid malformation of the lung. And I have also mentioned in the lecture, if you introduce barium from the esophagus and barium from the colon, and you fail to reach this particular lesion, you know that it should be a cystic adenomatoid malformation. But this lesion should be considered first as congenital diaphragmatic hernia, because hernia is much more common than cystic adenomatoid malformation.
Pneumoperitoneum.
And
intestinal obstruction.
yes, and this is intestinal obstruction because of the presence of multiple air fluid levels, and you got air inside the peritoneal cavity with marked elevation of the diaphragm.
Mid-periodic glioma.
Yes, and this is brainstem glioma. You got flattening of the fourth ventricle, expansion of the bones, and exophytic extension of the tumor surrounding the basilar artery, which is one of the classic criteria of the glioma.
Lymphadenopathy bilateral.
Yes.
Could be sarcoiditis, could be TB.
Then what?
But with the cough and intermittent fever, a TB.
TB, yes. And you should consider the TB as one of the differential diagnoses for lymphadenopathy in the pediatric age group. Previously, this lesion was known as minimal lesion, which was also called the primary tuberculosis, meaning that there is a focus in the lung and lymphangitis as well as lymphadenitis. Its new name is Ranks complex. Whatever the name, and this is primary tuberculosis. Yes, and this is Hirschsprung disease. And you got the aganglionic segment between the rectum and the sigmoid colon with marked proximal dilatation typical of Hirschsprung disease.
Hypoxic ischemic encephalopathy.
Yes, and this is hypoxic ischemic encephalopathy with profound ischemia. And you know that it is profound by the presence of multiple hemorrhages, which mean that the vessels feeding the wall of the arteries are also affected. Then the arteries are damaged and they bleed. And you know, whenever you see this, and you know that this patient is about to die or even he is dead as well. Okay.
Pneumonia.
Yes, and this is
Right upper lobe.
patchy opacity in the upper lobe, diagnostic of pneumonic consolidation.
Microcolon.
Yes. What is the possibilities? What are the possibilities?
Meconium ileus.
Meconium ileus, ileal atresia, and congenital aganglionic colon. Then how to reach one of these whenever you see filling defects in the distal part of the colon or the terminal ileum. If the terminal ileum is opacified, then you consider the possibility of meconium ileus. Yes, and this is Dandy-Walker malformation. There is a big cyst in the posterior fossa. The posterior fossa is expanded. The cyst is directly communicating with the fourth ventricle because the vermis is aplastic. The cerebellar hemispheres are hypoplastic, and the supratentorial ventricles are dilated. These are the criteria of Dandy-Walker malformation. Yes, what do you think? Emboyema. Why it is not an abscess?
Localized.
No. Actually, to differentiate between the emboyema and the abscess, there are many differentiating points. Number one, the abscess is rounded, the emboyema is elongated. Number two, the abscess is not surrounded by compressed lung, but the emboyema is surrounded by compressed lung. Both may contain air fluid level, but if there is an extension along the costal margin, you can see the split pleura sign, which is also diagnostic of emboyema. And this is emboyema because of the presence of compressed lung tissue adjacent to the lesion.
Obstruction.
Yes, proximal intestinal obstruction. This is the CT scan.
Volvulus.
No.
Interception.
Intersusception, yes, and this is not the site of the volvulus. It is you can see a loop inside a loop, and this is intersusception with obstruction. الوقت انتهى، انا بس هعيد الدخول وكمل مع حضراتكم تاني ان شاء الله. دكتور شريف. انتوا معايا على الخط؟ يا شباب الأمة.
مع حضرتك يا فندم، كمل.
طيب انتوا شايفين الصورة؟
تمام، عند الانترسبشن.
ايوه خلاص، احنا خلصنا الحالة ديت، هننطلق على اللي بعدها. يلا. يلا يا شباب.
Hemorrhage intracranial.
Okay, intercerebral hemorrhage in a male patient, 2 years old. And this is important whenever you see hemorrhage in the pediatric age group inside the brain parenchyma with no history of trauma. You should suspect one of three. Either the patient had some sort of coagulopathy and he is bleeding, like many of the thrombocytopenia and so hemophilia and others. Number two, there is an underlying arteriovenous malformation. Number three, there is an underlying tumor. Either this is a arteriovenous malformation or cavernoma. This can be solved by MRI. And also the issue of a brain tumor can also be assessed by MRI. But in the presence of history of trauma, you consider it post-traumatic hemorrhage.
Medulloblastoma. Neuroblastoma.
Neuroblastoma. Very good. And whenever you see a mass in the chest of a child, you think first of a neuroblastoma. And you know the relation between neuroblastoma and the age. You may remember that the neuroblastoma occurs up to the age of 3. From 3 to 10, you consider the more mature. Yes, and after the age of 10, you consider ganglioma, which is a mature form. Okay.
Lipoma. Corpus callosum.
Corpus callosum.
Yes, and this is corpus callosum lipoma, and also you do not see the rest of the corpus callosum, the splenium and part of the posterior body. It is also dysgenesis.
Abscess.
Yes, abscess. Yes, okay.
Microcolon. Secondary to
Microcolon. Yes, what are the possibilities?
meconium ileus.
أيوة.
Ileal atresia.
Ileal atresia.
Ileal atresia and
Ganglionic.
Ganglionic.
And this is, of course, you cannot differentiate the three, except if you see filling defects in the colon or the ileum, then you can diagnose meconium ileus. But the two other conditions, it is very difficult to diagnose from the ileum studies.
Hemangioblastoma or bilocystic?
No, you should not mention hemangioblastoma unless you have a definite clue for this. But if you see a cyst with an enhancing mural nodule in the posterior fossa, then you consider pilocytic astrocytoma until proved otherwise.
Abscess, lung abscess.
No.
Pneumatocyte.
Yes, and this is nematocele. An air-filled, thin-walled cavity within the lung is a nematocele, which is one of the sequelae of pneumonia in the pediatric age group.
Hypoxic encephalopathy.
Yes, hypoxic ischemic
Ischemic
encephalopathy with global
reversal sign.
Yes, the reversal sign with bright cerebellum and the global ischemia of the cerebral hemispheres.
Lobar pneumonia.
Which
Right upper lobe.
Very good. Okay. And this is lobar pneumonia, and you see an opacity with air bronchogram, and in the lateral view, it is confined to the upper lobe.
Again, microcolon.
Yes, and this is microcolon, and you should consider the three different possibilities. And if you see here, and you may can be able to elicit some of the filling defects in the distal ileum, which may suspect the possibility of meconium ileus. But this colon was found to be totally aganglionic colon. The both conditions were existing together.
Pilocytic astrocytoma. No. DXA.
DXA, pleomorphic astrocytoma, is a cyst with an enhancing mural nodule, and the nodule is peripherally located adjacent to the meninges.
There is prominent right artery, pulmonary, lower lobar pulmonary artery. Prominent vascular anomaly, but I don't know the name.
AVM, no. This is normal appearance because the heart is covering the rest of the pulmonary vessels.
Normal.
Miliary shadow. There is miliary
Normal.
shadow. Looks like miliary shadow. Maybe in the lateral view. Maybe it's evidence. Retrosternal space. Maybe TB space. More.
External space.
Yeah, there is some miliary shadow. Maybe it is TB or metastasis
No,
according to the history.
if you feel that there are miliary shadows, then you can elicit these miliary shadows here. But actually, the pathology here is this sign with which I have emphasized in the lectures, and you should see that the lower dorsal spine should be more black than the upper dorsal spine. But if you see that the lower dorsal spine are opaque, then you should consider a pathology. If you go to the frontal view and you see an opacity here, and this opacity does not silhouette the cardiac border, meaning that it is posteriorly located, and this is left lower lobe pneumonic consolidation. This is important.
Retrocardiac, doctor? Left
Yes, this
retrocardiac.
triangular opacity, yes, posterior to the heart.
Again, microcolon.
Microcolon, and this is meconium ileus because you see
Filling
filling
defects.
defects in the terminal ileum, and this is meconium ileus. This is without contrast, and this is post contrast, and this is MRI flare image.
Subarachnoid hemorrhage with hydronephrosis.
Sorry?
Subarachnoid hemorrhage look like with hydrocephalus.
Subarachnoid hydrocephalus? What do you mean?
Subarachnoid hemorrhage with hydrocephalus.
Okay, and if it is hemorrhage, it should appear in the pre-contrast, but hence it is more evident in the
Meningitis.
Yes, and this is basal meningitis, and you know that basal meningitis will affect the vessels in the subarachnoid, in the subdural space, and it will result in ischemic changes of the affected areas supplied by the vessels that are affected. Then this is basal meningitis with some ischemic changes in the basal ganglia.
Pneumopericardium.
Yes, and this is pneumopericardia, and they said that it is due to gastropericardial fistula from previous surgery, but it's just enough to say that this is pneumopericardium.
Again,
Microcolon.
microcolon.
Yes. And then this was iliac atresia. You see the atretic segment, which is sorry. You see this, and this is the atretic segment in the distal ileum and the proximal iliac dilatation and the distal attenuation of the colon.
Communicating hydrocephalus.
Yes, and all right. This is communicating hydrocephalus because all the ventricles are dilated, the fourth, the third, and both lateral ventricles. This is communicating hydrocephalus.
Hirschsprung.
Yes, and this is Hirschsprung disease, and you got a significant length of a ganglionic segment in the sigmoid and distal part of the colon. No. Hydrocephaly, yes, in the falx is present, and most of the brain is transformed into a big sac filled by CSF, and the presence of the falx is one of the important features of hydrocephaly.
Lung abscess.
No,
Aspergilloma.
Aspergilloma?
No.
Hydatid cyst, hydatid cyst,
Yes,
rupture.
this is ruptured hydatid cyst, and you got the endocyst, which is crumbled within the cavity of the hydatid cyst, and you got some inflammatory changes around.
Again. My God.
Yes, and this is a
Ileal
ganglionic colon. You see, this is the colon in the gross specimen and the dilated small bowel around. Actually, we cannot reach this diagnosis from these images. And you say microcolon with the possible differential diagnosis, and at surgery, it will appear, they will discover the cause. This is CT without contrast, then with contrast, and this is a SPECT scan, which you can see the viable brain tissue.
Hypoxic encephalopathy also?
Yes, but secondary to,
This was contrast or without?
yes, with contrast, and this is meningitis because of the
Meningitis.
enhancement of the meninges and total ischemia, and you see the affection of the basal ganglia,
Basal
which is a
ganglia.
dangerous
Bad
sign.
prognosis.
And the SPECT scan shows no evidence of perfusion in the brain tissue. And this is meningococcal meningitis with brain death.
Definitely hernia.
Lung aplasia.
Yes, and this is lung aplasia because of this. This is a perfusion scan, and you see a solitary lung. The right lung is not present, and the heart and the mediastinum are displaced at the site of the lung, and this is diagnostic of aplasia. But without this image, you may say that this may be a pleural effusion and maybe a hypoplastic lung, but you cannot see the aeration. There are many possibilities for this. But whenever you do not see any perfusion, you know that the lung is not there.
This subarrenal.
No, this is the kidney.
Multicystic dysplastic renal
Yes, very good. This is multicystic
disease.
dysplastic kidney, and you can see the normal kidney on the right side, and the left one is replaced by many cysts, and there is no renal tissue, and there is no function.
Big fat.
Sorry?
Polycystic astrocytoma.
No,
Big cell.
no.
There are two cysts with enhancing neural nodules.
No, it's only one cyst with calcified nodules. This is without contrast.
Hydatid?
Yes, and this is a hydatid cyst. An intraaxial cyst with calcification is diagnostic of hydatid cyst.
Interstitial lung emphysema.
No.
Respiratory distress syndrome. If it is premature, it is highly membrane.
No. The lungs are aerated, and you can see the vessels.
Hyperinflated. Hyperinflated.
Let us say. But do you see this line? What do you think?
Minimal pneumothorax.
Okay, and this image is provided here because of this. And in the neonates, whenever they are obtaining chest X-ray, there may be skin folds. And this skin folds may be mistaken for a pneumothorax. The best diagnostic clue is you can see that the fold is extending outside the chest. And this means that this is a skin fold and not a pneumothorax.
Regional atresia, iliac atresia.
Jejunal atresia, yes, this is the stomach and the duodenum. The proximal part of the jejunum is blunted or obstructed, and this is proximal jejunal atresia.
Craniopharyngioma.
Yes, and this is craniopharyngioma. We have three criteria: cyst, calcification, and solid neural nodule. Two of the three criteria are enough, but the cyst should be one of the two. Then you see a cyst with calcium are enough to diagnose craniopharyngioma in the suprasellar area.
Sir, regarding this region, how can we differentiate it from suprasellar dermoid?
Yes, dermoid contains fat, and intracranially you should see the fat, and you depend on the presence of fat to diagnose the lesion. But in the mouth floor, for example, and in certain locations like in the orbit, you do not need to see fat to diagnose dermoid cyst. But intracranially, you should see fat to diagnose dermoid cyst. This is a very important issue.
Foreign body in the left lung.
Foreign body.
Yes, and this is foreign body inhalation on the left side. This is inspiratory and expiratory films, and you got persistent hyperinflation of the left lung, indicative of a inhaled foreign body.
Infantile polycystic kidney.
Infantile polycystic kidney or autosomal recessive polycystic kidney disease. Markedly enlarged kidneys, they do not secrete contrast material, and they are replaced by extensive, numerous, very minute cystic lesions.
Microgyra. Gyra. Gyra.
No.
Gyra.
Gliomatosis, no. You see this frontal horn?
Side, left.
You see this frontal horn?
Yes.
Yeah, what do you think? No, this is hemimegalencephaly. The left cerebral hemisphere is big compared to the right one. The ventricle is big compared to the right one. There are abnormalities in the white matter of the hemisphere, as well as brachygyra on the surface of the hemisphere. All of these findings are diagnostic of hemimegalencephaly.
Bronchial cyst.
Bronchogenic cyst, yes, and this is a cystic lesion near the site of the carina, and it is typical location and typical appearance.
عارفه دكتور استاذ ممدوح الليجن فين في الاكس راي؟
هو مش باين الحقيقة إلا بصعوبة شديدة. And you see this indentation on the back of the trachea here. And you see this lesion is indenting this area, and this is the site of the lesion. But If I give only this chest X-ray, it would be very difficult to elicit the site of the lesion.
Esophageal atresia H shape.
H shape.
Peanut.
This is the esophagus and the trachea, and the site of fistulous communication.
Papilloma, choroid plexus papilloma.
Choroid plexus papilloma, an intraventricular cauliflower lesion strongly enhancing with lobulated border in a child is diagnostic of choroid plexus.
Doctor, in both frontal and occipital horns, it is the same patient?
Where is the same? This is not the frontal lobe. This is the occipital horn, but the coronal images are coming from the back to anterior. Okay,
Yes.
and it is not in the. This is the coronal image is not an axial image.
Yes, okay.
Neuroblastoma.
Neuroblastoma, and you should diagnose this every time as a neuroblastoma. Then the patient will go to have a CT scan. And when at the CT scan, then you will see fat, you will see calcium in the anterior mediastinum. Then at that time, you can diagnose teratoma. But if you look to the chest X-ray of a child and see a mass, then you should say that this is a neuroblastoma. If anyone said to you that, look, there are foci of calcification within the lesion, yes, neuroblastoma contains calcium in 85% of the cases. Then you cannot diagnose teratoma from the plain X-ray. You need the CT scan to see the fat and calcium. Microcolon. What do you think?
Secondary to meconium.
No,
The spelling
this is esophageal atresia with significant dilatation of the colon. And you see the colon is small, this is microcolon, and there are three possibilities.
open lip Scheisenkiewicz.
Closed
Closed
lip
lip.
Scheisenkiewicz. Yes, there is no communication between the cleft and the ventricle, and the cleft is lined by cortex, and this is closed lip Scheisenkiewicz.
Lung abscess, right upper loop.
Yes, and this is lung abscess and horizontal air fluid level.
Hepatic.
Hepatoblastoma.
Yes, hepatoblastoma, which is the most common hepatic mass in the pediatric age group, and you see a big tumor which also may contain calcium. What do you think? This is a very characteristic appearance, which is known as bat's wing configuration of bilateral large open lip Scheisenkiefel. And this is a very sizable open lip Scheisenkiefel on both sides, and you got communication with the ventricular system.
Pneumothorax.
Pneumothorax and
Lung collapse.
and
Surgical emphysema.
and
Pneumomediastinum.
yes, and they all are these the sequelae of this endoscopy, and you got esophageal perforation and pneumomediastinum, surgical emphysema, pneumothorax, and lung collapse.
Doctor, how to diagnose esophageal perforation? يعني how to be sure from the
No, from the history. And this patient got severe dyspnea after upper GI endoscopy, and the pneumomediastinum, one of the causes is esophageal perforation, and the history is leading to this diagnosis. Then you consider all of these the sequelae of the endoscopy.
عفوا دكتور لو في in adult patient spontaneous pneumomediastinum and pneumothorax and suspected esophageal perforation, what is the specific diagnosis? What to do?
Actually, the esophagus do not perforate spontaneously unless there is a malignancy or so. But the perforation of the esophagus, Burhoff syndrome, should be preceded by a severe attack of cough or vomiting, and this will lead to a tear in the intima in the wall of the esophagus and may lead to pneumomediastinum.
Okay. Double duodenal atresia.
Yes, and this is the duodenal atresia, classic appearance by barium.
Epidural hematoma, right? Epidural hematoma.
Yes, convex inner margin.
Tension pneumothorax.
Yes, and this is tension pneumothorax, compression of the diaphragm, shift of the mediastinum.
Pneumoperitoneum.
No. What?
Calcification.
Yes, you see calcium in the abdomen. What do you think?
Peritonitis. Meconium peritonitis?
Meconium
peritonitis, yes. I think this is the only diagnosis in the neonates whenever you see calcium in the plain film in the abdomen and you think of meconium peritonitis.
Is it abnormal
signal intensity noted in the temporal, bilaterally, and also in the
herpetic encephalitis?
Yes, and this is herpes encephalitis, bilateral, almost symmetrical. It may be not symmetrical lesions in the temporal lobe, which shows high signal in the FLAIR images. This will also show diffusion restriction, and it will not show contrast enhancement. Diagnostic of herpes encephalitis.
Like adult?
Yes, exactly the same.
Consolidation of the lower lung, at which
lung?
Retrocardiac left lower lung.
This arrow points to the fluid level or a fluid in the costophrenic angle, and this is effusion. The effusion is not seen in the frontal view if it is small, and it can be seen in the lateral view because the posterior costophrenic angle is more dependent than the lateral costophrenic angle. Then fluid will accumulate here first, then it will appear in the frontal chest X-ray.
Hepatoblastoma.
Yes, hepatoblastoma once more, and you see calcium in the tumor. This is okay for the tumor. It can show calcium.
Focal heterotopia, not in the frontal left.
And this is heterotopia, focal type. You got a mass of cortical tissue within the white matter of the left frontal lobe. Very good. This is a good diagnosis.
Esophageal atresia. Esophageal atresia.
No, I didn't hear the answer.
Continuous diaphragm sign.
Yes, very good. Very good.
Pneumomediastinum.
And the continuous diaphragm sign, you see the whole length of the diaphragm, which is diagnostic of pneumomediastinum. Very good.
Other regression syndrome?
No, you see that.
Pyloric, no air in the abdomen.
Yes, and this is a sign of
esophageal atresia.
Yes, gasless abdomen is a sign of esophageal atresia without tracheobronchial fistula, esophageal fistula. And you can see that the dural tube is coiling in the proximal esophageal pouch. And this means that the esophagus is atretic. And whenever you do not see gas in the abdomen, meaning that there is no tracheoesophageal fistula.
Hemangioblastoma.
Yes, and this is hemangioblastoma because you have the angiograph. And the angiography showed that the nodule is enhancing or a hypervascular, which means that you are dealing with hemangioblastoma, but the astrocytoma, the nodule is hypovascular. No.
Tension pneumothorax.
No.
Hypoplasia of the left of the right lung.
No, and see the vascular markings.
There is paramediastinal obesity.
Where? This one?
Right, on the right side.
This
yes.
one?
Yes.
It's the cardiac border. It is displaced to the opposite side. Yeah. What do you think?
Lung collapse.
No?
Foreign body? On the left.
Very good. Yes. Bravo, Alik. Foreign body inhalation, and you got the most important cause of hyperinflation in the pediatric age group is that when you think of foreign body inhalation, this is very important.
Zwar?
No, this is
Meconium peritonitis.
yes, and this is whenever you see calcium in the abdomen in the newborn, and this is meconium peritonitis. Yes, and this is CT scan with contrast, and you see the ventricles are separated from each other, meaning that the corpus callosum is present, and you got a very jet black lesion in the corpus callosum, and this is fat, meaning that there is agenesis of the corpus callosum associated with lipoma as well. Then this is callosal agenesis with lipoma. How do you know that this is fat? And you compare the density by the density of the CSF, and you got more hypodensity. Then you may say that this may represent air. Then I will say, what is the reason for the presence of air in the corpus callosum? Nothing, but fat is more logic.
Bilateral lobar pneumonia.
Yes, bilateral bilateral pneumonic consolidations. They are not affecting the whole lobe, but they affect part of the lobes.
Wilms tumor.
No, the kidney is not involved by the mass. You see that the kidney is flattened posteriorly, but the mass is anterior to the kidney.
Neuroblastoma.
Yes, and this is neuroblastoma, one of the three big masses in the pediatric abdomen: hepatoblastoma, neuroblastoma, and nephroblastoma, or Wilms tumor.
Then they walk or
No?
right. Carry too.
Carry. And this is carry too. You got a small size posterior fossa, attenuation of the fourth ventricle, a slightly dilated third ventricle, dilated lateral ventricles were colpocephaly, and the inverted free sign due to hypertrophy of the basal ganglia.
Multiple lymphadenopathy.
Yes, lymph nodes in a child, as I have mentioned before,
TB.
we have
TB.
4 diagnoses. TB should be considered in every case, and sarcoid, of course. Then you got lymphoma and metastasis. But whenever you see breakdown or calcium, and this will support the possibility of TB, but you should consider TB in the differential diagnosis of any lymphadenopathy in the pediatric age group. الوقت خلاص على فكرة.
Neuroblastoma.
Neuroblastoma, yes, and you are right, neuroblastoma.
Pilocytic astrocytoma.
Yes, pilocytic astrocytoma, cyst with an enhancing neuron nodule.
Again.
Bilateral pulmonary
Bilateral.
artery venous malformations. Okay, the time is over. Thank you very much.